Facebook. It'll take a little bit. Connecting live video. All right. We are ready to go live on Facebook. We are live on YouTube. Let me just add a description.
And we're recording too, right?
Yes, of course.
People did ask if there was a recording. So.
Yes, it'll be a recording. It'll be uploaded. It'll be in a lot of places. We are about to go live on Facebook, and then I will be going live on radio, and that's when we'll start. Okay. Synchronize your watches. We are live on YouTube, and we are going live on Facebook. Live video is starting. We give me another test call out, Chuck.
Yep, testing 1 2 3 1 2 3.
All right, awesome. We're live on Facebook. We are live on YouTube, and now we're going to see if we make sure that we can go live on GCPR.
And that's where people are listening, right? GCPR.
That's good. That's the live radio. That's the live radio.
So they can hear there, and they can hear on Facebook and Instagram.
And the other side of information says, congratulations on the debut, and I see you and hear you on YouTube. Thank you. All right. We are going live to GCPR radio in 3, 2, 1. Connecting. All right. We are live. Hello, everyone. Hello, and welcome to the launch episode of To Your Healthcare. The radio and live show where we talk all about universal healthcare, the movement in the United States, healthcare justice, and all the constellation of related issues. We are so happy to be here live, thanks to GCPR Radio, and also broadcasting live on our Facebook and YouTube page. If you're listening to us not on one of those, it is a good chance you're listening to us post-live on podcast platforms with the recording. My name is Simon Hutton. I'm a communications director for One Pair States, an organization that fights to achieve universal healthcare nationwide, a national universal healthcare system for the United States through the states by trying to win universal healthcare in the States, and I'm here with our president of One Pair States, Chuck Pinocchio. Chuck, you want to give yourself a quick introduction?
Sure, absolutely. Thank you, Simon. Very excited to be here with our inaugural listening audience. This is a breakthrough moment, I think, for One Pair States. We're taking our communications platform to another level. So we can have more in-depth conversation, interaction, bring in guests, hear our healthcare stories and strategy on how we're going to win. That's the bottom line for me. Why I'm in this fight is to win. And that's really what I want to make a major focus of the work that we do. So thank you, Simon, for doing all the technical, and shout out to Jeff Kennedy and other partners who have given us, provided this platform for us. Very excited. I'm in Mount Rainier, Maryland. So I'm 3 hours, 3 time zones east of you. So it's 6:13 here and 9:13 out in Corvallis, where you are.
3:13 actually, earlier. Roll it back.
I'm thinking forward.
Yeah, I'm not off the coast of Spain. Um, yeah, and I'd like again, yeah, big thanks to Jeff Kennedy, GCP, and everyone at GCPR Radio. One Pair states, if you'd like to learn more about our work to achieve universal healthcare through the states, I suggest that you check us out at onepairstates.org or on Facebook, Twitter/X, Instagram, all the social media platforms, TikTok at One Pair States. We are really excited. We have two big guests coming in today as well, and I'm going to let Chuck give them give you a quick preview of who you are. You want to sort of list off who we're going to get coming in as guests throughout the show, Chuck?
Yeah, first off, we'll have in about 15 minutes, we'll have Caroline Coram, who is this just amazing person. She's a retired nurse, retired doctor, and will have an incredible healthcare story to share with you between during the half hour of 6:30 to 7 Eastern. Caroline is a very active member of One Pair States. She's active in our communications work group, one of the co-chairs, and she is just a heart person, just a wonderful person. And then at the top of the hour, 7 o'clock Eastern for Pacific, we'll have Dr. Walter Tsu, the former health commissioner, Philadelphia. A dear friend is Walter. He's going to be coming in and speaking to the question of healthcare as a public good, which I think is a wonderful frame for the work that we do. Healthcare needs to be seen as a public good, not to be a yet another platform or another industry to be sucked dry of wealth, not another wealth extraction mechanism for Wall Street and Silicon Valley to operate. It needs to be seen as a public good, and it needs to be elevated so that healthcare not only is a human right, but is a practical good. It's pro community, it's pro individual, it's pro business, it's pro school, it's pro LGBTQ, it's pro the entire fabric of our society. So that's what Walter's going to be focusing on. Very excited to have Walter coming with us as well.
Awesome. And in the 15 minutes up to that, we're just gonna check in about the current state of the movement in the U.S. Obviously, we're coming up to a huge election in around 40 days, I think. Also, Chuck and I were in Chicago during the Democratic National Convention. So I think we're just gonna let's set the stage for where the universal healthcare movement is at, where we're going, where we hope to go, and what we've seen recently. But first of all, I just want to say, how are you doing, Chuck? Are you doing good?
Balancing a lot of balls. I turned 65 this Sunday, so I move into the Medicare world. Actually, I didn't realize I moved into the Medicare world post-tense on September 1st. So I'm juggling a lot of sort of personal issues, trying to take care of some personal medical issues, and looking forward to this election that's coming up. We're now under 6 weeks. Focus very much on that. Have friends across the country. We'll be doing canvassing. We're a nonpartisan organization, but we support candidates that support not only healthcare justice, but health justice. Something we'll be returning to over and over again is that we work on intersectional politics here. We work on the intersection of healthcare and health justice, which is housing, food security, climate, you name it. Though the issues that wrap around our entire lives, that's the kind of work that we do. And that's the kind of strategy that we've got that is going to get us to victory. Actually, as we talk about radical visioning, we see the success in the future, and we're going to be talking about how we achieved and how we actually achieved the success by seeing the success in the future and then reverse engineering it. So that's really what keeps me centered in terms of my spirituality, in terms of my focus, in terms of my organizing, in terms of my energy. So how are you doing, Simon? How are you holding up?
I am looking at tech stuff real quick, but yeah, no, I'm honestly, I'm balancing excitement, anxiety, trepidation, energy. There's a lot going on. This fight for universal health care, the election. I want to do all we can do to try to work towards creating an ethical healthcare system, and beyond it, just moving the country in a better direction. And I mean, like, so many things feel like they're coming to a head, right? There's so many sort of concurrent streams on all these different social justice issues. So I will say excited, nervous, and very happy to be on right now. Actually, I'm thrilled because it feels like we're doing everything we can to get our message out. But I want to sort of set the stage here, and I want to read something off to our listeners, actually, because as I mentioned, Chuck and I were in Chicago during the DNC, and we were at the conference of the Progressive Democrats of America, Progressive Victory, and a note about where we're at from the sort of Democrat side, the Democrat side of the political sphere, is that in 2020, in the Democratic platform, they actually had this phrase, which I want to read out. It says in the 2020 Democratic National Platform, it was, Democrats will also empower the states as laboratories of democracy to use the Affordable Care Act innovation waivers to develop locally tailored approaches to health coverage, including by removing barriers to states that seek to experiment with statewide universal health care approaches. This was in the DNC platform, a sort of nod towards the work to use states as laboratories to sort of develop universal health care. And that has been removed, my understanding is, Chuck, from the Democratic platform in 2024.
I'm not sure it was removed so much as that it just did not reappear. And that may sound like a distinction without a difference, but what happened in 2020 is that we had maybe our greatest champions, right, for national Medicare for all, but also state-based universal health care. Our greatest national champions are Representative Pramila Jayapal out of Seattle, and in the House of Representatives, and Bernie Sanders in the Senate, and they both had a hand in crafting that 2020 platform. So there was an affirmative, intentional, proactive effort to get that language in there. Those two individuals were not part of the drafting of the 2024 Democratic National Committee platform. So we're simply going to have to take 2020 and push it into 2024, 25, and get folks to understand that the State-Based Universal Health Care Act, which is being carried by Representative Ro Khanna in the U.S. House, being carried by Ed Markey of Massachusetts. Khanna is from California, Ed Markey's from Massachusetts. For the first time, is carrying it in the U.S. Senate. Is that we can win on this. We can win on this because our legislation has appeal. It has broad appeal across the political spectrum. So we're in a very exciting moment. So we're not going to allow anything to stand between us and success.
All right, and I see we have our first guest coming in. Caroline, we will get to you in about 10 minutes.
Okay.
But Chuck, I'd like you to elaborate a little more because everyone listening may not know about what the State-Based Universal Healthcare Act is, why it's important, and what it does. So could you sort of give us a rundown on that?
Sure. Yeah. In a nutshell, it's if for those of you keeping score at home, HR 6270 is the language of the House bill, HR 6270, and we also have a Senate bill. I said Ed Markey, that's S 4817. So HR 6270. S 4817, State-Based Universal Health Care Act. It's the same language. Both bills are the same. And its design is to provide financial and legal waivers. So states can bring federal healthcare dollars back to the states to create an efficient one-payer, and some people call it single-payer pool, an efficient pool that will allow for the delivery of cradle-to-grave, comprehensive healthcare that restores the the central relationship in healthcare, which is the patient and the provider, and which has been taken away from us, as we all know, by the medical industry, by the insurance companies, by big hospitals, by big pharma, and by the medical manufacturing industry. So what we're doing here is providing a pathway to get us to national Medicare for all by modeling it at the state level. That's what the State-Based Universal Healthcare Act is for, is to give us that opportunity to create models at the state level, and that those models can then serve as a catalyst to create a national bill, I should say, or create the momentum behind a national bill, which already exists. That's Pramila Jayapal's National Medicare for All bill and Bernie Sanders' National Medicare for All bill. But this is the way that Canada was able to get to national Medicare for all through a single province. In the 1960s, Saskatchewan, led by Tommy Douglas, who was the head of that province. He forged ahead and created a single payer Medicare for all type system in Canada, which has the same constitutional structure as ours. It's a federalist constitution, where more often than not, innovation begins at the state level, even at the municipal level. But once it's adopted at the state level, it then serves as a laboratory. It serves as a model, as an inspiration to create a national structure based on those principles. And as the historian in me reminds myself and my students and listeners, this is the way that the progressive era worked. The progressive era started in Milwaukee in the 1880s, went statewide in Wisconsin, and then was elevated by Teddy Roosevelt when he became president in the early 1900s. Same thing with the New Deal. The New Deal programs were largely modeled at the state level in Albany, New York, when FDR was governor of New York. So then when he became president, he elevated those state models from New York and made them into national programs, including Social Security, the National Labor Relations Board, and that what would later become Medicare and Medicaid with Great Society programs of Lyndon Johnson. Again, modeled at the state level. Same thing with civil rights, modeled at the state level. Same thing with women's suffrage, modeled at the state level. Same thing with ending childhood labor abuse, modeled at the state level, ended at the national level. So this is our history. This is who we are. That's how we create change across the whole of our history.
And while we were there, I mean, like, I have my own thoughts, but like while we were there at in Chicago for Progressive Victory, and just in Chicago during the DNC, seeing all the people, around, where do you think we're at on this fight? How did you feel being there in the thick of it, and what are sort of your reflections on that experience?
Well, the most exciting part, as you know, and a handful of folks know within our group, is that it was the conversation that I had with Representative Pramila Jayapal in the green room. This is before we went out on stage and discussed our own thinking on healthcare. It's amazing. She came to me in the green room, and I said, Representative Jayapal, nice to meet you. I'm Chuck Pinocchio, president of One Payer States. Would love to continue collaborating and taking this work that we're doing to the next level. Knowing that Pramila Jayapal was the author of our legislation, of our primary legislation, the State-Based Universal Healthcare Act. And what she said to me is, really good to meet you. What we really want to do is coordinate as much as possible the work that you're orchestrating at the state level with the work that we're doing at the national level. We want to bring together our strategies, our tactics, our communications, our messaging, our coordination of introduction to the bills, how it is that we talk about the problems of the medical industrial complex, all of these things. It was just a dream come true, quite frankly, because I've been thinking about this, working on this, as you know, Simon. We've had many conversations back here in DC, and then a month later in Baltimore, and then a month later in Chicago. And that is that we're very intentional about what it is that we do and how we do it. And that looks like what we'd be talking about. We don't want to cut into Caroline's time. I can go on and on about this quite a bit, but just to put the larger conceptual framework together, after that meeting, I was then pointed to Representative Jayapal's team, her staff. And I had a meeting last week with her brand new healthcare legislative aide. And we're going to work. We're rolling up our sleeves and we're going to figure out how to get all this done together, working together. So I'm extremely excited. Not everybody's on the same page at this point. We know this. This is a lot like building, it's a lot like building the railway track and the train, and the train's going to be moving out of the station and people will say, hey, I want to get on that train. That's what we're doing. We're building the track, we're building the train, and the train will be leaving the station soon. And people will say, that's the pathway to getting us to a civilized healthcare for all in the United States. And that's the path that we're going to follow. So all the naysayers, and there are people out there who just are very, very skeptical, even to the point of being cynical, and that's okay. We're going to win those folks over because of our success. And that once they see that happening, the train leaving the station, they can choose to stay in the station and just pout, or they can jump on the train and be part of the celebration and part of the victory and part of what it is that we're creating, which is bringing the United States into the civilized world and liberating our economy and liberating our citizens and creating an infrastructure to elevate, to lift everyone all together.
Yeah. Well, I think you kind of drove it home there. And we are coming up on our first guest segment. I want to take a moment to thank GCPR Radio. We are live on GCPR Radio. Currently live on One Pair of States Facebook page and YouTube page. You might be listening to this post live on running on GCPR Radio or on one of the many podcast platforms. This health to your health now has been added to. I encourage you to go and check out onepairofstates.org to look at our work. And I remind you actually that we are going to be doing this show monthly on the fourth Thursday of every month at 3 to 5 Pacific and 6 to 8 Eastern time. So we hope you'll keep joining us. Now I will bring in our first guest, Caroline Coram. We are going to talk a little bit about her personal experiences with the system of with the American healthcare system, and I'll just let you introduce yourself, Caroline. How are you doing? And how did you get involved in this work to win universal healthcare?
Well, hi, Simon. I'm glad to be here. I've had a little bit of a cold, so I hope I don't sound too awful. Maybe just a little bit hoarse. But I, I was just looking at some notes I had made, and everything just sounds really catastrophic. And I don't like to think of myself as catastrophic. No one does. But I really became involved with this through a couple of different avenues. It seems like healthcare and access to healthcare has been a theme just sort of running through my life. And, it's a bit ironic because I probably had much better than average access to healthcare. I've been very fortunate in that respect. But I think, especially before some of the protections that we have now, that was always very tenuous. It is for most people. And then sort of midlife at a terrible time, not that there's ever a good time, I was diagnosed with a serious illness and really started looking more critically at the health insurance lack of a system and just how easy it is to lose your coverage, and that was for a number of reasons. But it's just, the biggest issue is just how the whole system is designed. And so many people around me that had the same medical condition were getting in the same boat. Tenuous access to health care. Some people did pretty well, and others either didn't have care or were facing the constant denials, or the huge out-of-pockets were just eating them alive. And it really caused barriers to trying to get better and get the health care they needed and, uh, just live a good life.
And you were personally you were part of the of delivering healthcare yourself, right? You saw this in action, right?
Oh, I definitely was. And that was a really interesting other part of the whole scenario. I think it really sort of brought me right up to the brink of sort of coming at it from the healthcare side. I was a nurse and very frequently worked with patients trying to deal with, again, the constant denials and just wildly different kinds of bills that they would get, for for their care, for what was covered, for what was not covered. They had bills coming at them from everywhere, from the hospital, from another healthcare system, from a lab, from a doctor. And, it's enough to make your head spin. Really is.
Yeah.
And so many times, I think the biggest frustration was that, the overwhelming nature of that, but also what seemed like very, very random denials of just basic standard care that there's no way they shouldn't be getting.
Could you actually expand on that? Like, how exactly? Because I think a lot of people can be confused by this. How exactly how do denials of care happen in our healthcare system? Do you? Or, I mean, I know you said it was random, but if you can talk a bit about that.
Yeah. So, you know, um, I think when people get healthcare for most conditions, there are fairly standard protocols that, physicians will implement when they deliver care. We need to run this set of tests, and here's sort of the schedule we follow. Um, and especially depending on how much your disease process or your health complication looks, quote unquote, like, the normal pattern that people follow, it may stick more closely or less closely to that. But, you know, there are going to be certain tests you're going to run and exams you're going to have, that sort of thing. And so, I mean, very clearly, if doctors didn't do that, it would be very irresponsible, you know, possibly malpractice or certainly inferior quality of care. And so, obviously those get billed to insurance. And for most of our patients, they would be paid. And then, a certain percentage of them, and I can't give you an exact number, but they would just come back with denials. And the patient would call us and say, why have they denied covering this care? I was told I needed this. It was just basic standard stuff. Why in the world would it be denied? I don't have a good answer for that, except now I think in retrospect, more and more of us know, we've heard that there's probably some algorithm out there that's deciding that they don't need that care. And it's not anything that you can see a good reason for, and they couldn't get a good explanation for it at all either, even from their health insurance.
So that begs the question, is it actually random or is it intentional? Is it
Yeah.
baked in? I mean, the charge here, I mean, the industry is largely driven by the profit centered nature of the industry, which is compelled by what Wall Street demands, which are quarterly profits for their shareholders. And this is unlike any other advanced industrial society, right?
I based on what I know, I believe it is, and I think I'm fairly familiar with, reasonably familiar with how other developed countries do things. They have a combination of different kinds of systems, but typically one thing they have in place is a standard process for what will be covered, and they have professionals who have medical and clinical history to evaluate what's appropriate to be covered and what's not. They have very strict standards, and as long as you're getting something that's reasonable and certainly standard of care, um, it's going to be covered. And that's a big, big hole in our system is that we do not have anything like that in the US. We have private companies, people without necessarily even any clinical experience making those determinations. Sometimes it's probably computers too.
Well, also, yeah, another aspect of this is, there are, those algorithms, in many cases that are sometimes making this choice. But then once a denial happens, then there's a whole struggle at play, because either if it's a smaller practice, the doctor directly has to get involved, or there's nurses that have to spend their entire job fighting. Oh, well, you just raised your hand, so I think you might have had that experience. But actually, yeah, if you've had that experience, why don't you talk about, as like a nurse or a doctor, fighting denials with private insurance companies?
It is very frustrating and demoralizing because I spent hours on the phone with insurance companies, a lot of that time on hold. And, sometimes it would be cleared up. Sometimes you couldn't reach a human. Sometimes they would say they would consider it and they would deny it again. Sometimes they would say, well, we have to talk with the doctor about that and get their justification. We can't talk to you. We can't just acknowledge that it's standard of care. And, especially when they want to take up a big chunk of the physician's time, that's a huge expenditure, huge cost to the system, to all of us who need healthcare. And it's a huge chunk of time away from that patient-physician relationship that is really going to result in the rendering of meaningful care. And it could feel extremely random because every once in a while we would have, if I got a no, we would have the second person make a call and maybe they would get something else. Every once in a while, usually they get the same answer, but every once in a while they'd get a yes. And it all seemed very, very random. It may have been programmed into the system some way. That's quote unquote proprietary, and I'm sure we'll never know. But I can tell you it was very, very frustrating. It was frustrating for me as the person trying to do it. It's frustrating for the patient. And it's hard on your people because you go home at the end of the day demoralized about not being able to focus on rendering meaningful care to patients. And, it's not a good use of resources at all.
Right. So that also speaks to, a topic that a lot of people have heard about, which is the growing problem of nurse-patient ratio, which is that increasingly nurses are just overwhelmed by the number of patients they have to care for. But on top of that, you're having to advocate and fight for the care that you need to actually deliver to those increasingly greater number of patients that you have to care for. What is that? Where else does that happen?
Yeah, it's true. It's funny because, within the last 30 minutes, I was listening to this report on the radio about increased productivity and great for the economy and all that. And I kept thinking, they're just loading more patients on those poor nurses. And, nurses operate in a number of different circumstances. There's outpatient nursing, inpatient nursing. And so the whole mix of things can vary from situation to situation, but especially when you hear about inadequate staffing in nursing, frequently that's going to be inpatient, as in a hospital, or sometimes in a long-term care facility, where people are resident, either temporarily or longer term. And but it also pertains to outpatient situations as well, because when you go to an outpatient office as a fairly healthy patient or somebody managing a chronic condition that's pretty well controlled, you frequently have very few people with an actual nursing credential and other staff that, not that they aren't well trained and competent to do what they do, but they aren't necessarily a licensed nurse. And then in the inpatient setting, it's really just a matter of how many patients a nurse has to take care of, render assistance to, and try to be there for as a resource. Um, I was on a continuing education call today, and they were talking about fall prevention. You do not want your patient to fall and hurt themselves if you're, especially in an inpatient facility. And it takes a lot of time and attention to be there for a patient to help ensure that they don't suffer, um, you know, something that's going to harm their health further than when they came in. If you don't have adequate staffing, if you can't take good care of them while they're there trying to get better.
Right, right. So, I mean, one thing that we should make a practice of here, Simon and Caroline, is provide people with resources so that the conversation, it gives people the opportunity to do a little bit of research and connecting on their own. National Nurses United is
Yep.
an organization that they've got terrific resources. It's a labor union, and are you a member of NNU, Caroline?
Well, I've been a voluntary member. I have not worked in a facility with unionized nursing.
Mhm.
And so where I am, that's fairly rare. It sort of depends jurisdiction by jurisdiction. They have worked very hard on the issue of staffing.
Right.
And there are a few states now that have passed staffing requirements for inpatient facilities. California is one of them, and I know a couple sort of in the, I think the upper mid-Atlantic, New England have looked at that as well.
Right.
And also there has been discussion about trying to implement that with long-term care facilities where Medicare provides a lot of the funding.
Right, right. So, so just to say for our audience here, check out nationalnursesunited.org.
Mhm.
That's a great resource. And then there's a great research source is Physicians for National Health Program, which
Mhm.
is pnhp.org. They've done a tremendous amount of research on a lot of these topics, PNHP. And then, of course, onepayerstates.org. We need to promote that every, 15 minutes? Isn't that what Jeff told us, Jeff?
It's 15. It's every half hour. We don't have to barrage them with one pair states quite that often. But yes, check out one
Yeah.
pair state.
So,
Right.
so maybe just to pivot over, you all, and then maybe tell a little bit more about your personal story as well. How you've had to, what it was like going through as a patient, your own cancer and recovery, and then and what that's like. And then you also went into a second career. You were a lawyer for a time, correct?
Yep. I was a lawyer before I was a nurse,
Hmm.
and I, uh, that's one of those themes that sort of follows you around about healthcare. Um, I, I really, when I was an attorney, you know, very excited to start my new career, started looking for jobs. Very quickly found out that most smaller firms do not offer health. Well, at that time, did not offer health care. And I was absolutely shocked and horrified because I, this was before any provisions of the Affordable Care Act. And so you couldn't just go out and buy your own policy, at least not one that was meaningful. And um, I really had no meaningful access to healthcare if in working for a small firm. And the vast majority, especially at that time, of attorneys worked for small firms.
Right.
So I ended up working for a financial institution, and they fortunately provided much better healthcare, but it really limited your career options. So worked in that field. But there was a lot of instability. There were a lot of mergers, a lot of acquisitions. Things would change. You'd have a job, look for your next job, and it seemed like it was almost like always working as a temp. And so eventually, I got kind of fed up with that. I had always been interested in the healthcare field and decided to go into nursing. Um, and so I did. Fortunately, you know, they offer good healthcare plans, most places, and so went into nursing. And but ironically, by the time I got into nursing, there were you were having the issue that many people have with um, a lack of resources, where it's just very hard to get on the roster, get in to see, especially a primary care physician, which, for healthy people, that's kind of what you need and where you go to just keep up with health maintenance and address any minor issues that you have. And so that was really, really difficult. And I had the opportunity at one point to change plans, and so I did. And that did seem to be a little bit better in terms of getting access to care. But I was really, really frustrated that I had great health insurance and I still couldn't get in to see a doctor, and I worked in the healthcare field. It was terrible. Um, Shortly after that, I was diagnosed with cancer, which is just, bad enough in and of itself. But it was I was really lucky to have good health insurance, but trying to deal with that um, and work, that was complicated. And um, our system, it just doesn't have a lot of safeguards in it, and what they are, you frequently rely on your spouse. They kind of seem to envision that there will be two spouses working, or at least that one person will have a very, very stable situation. And with being single, I didn't have a fallback option. Didn't have a spouse there with insurance. And so, for example, if you lose your job, you lose your health insurance. And eventually that's more or less what happened to me. Um, Fortunately, I was able to scrape together my savings and stay on Cobra for as long as I needed to. But it's a real hardship, and there are an awful lot of people out there that just can't do that because now it's just gotten so extravagantly expensive. Um, People do have the option now to get an ACA plan, but that's those have a lot of holes in them. One of the other OPS members and I did a presentation at one point a couple of years ago about how people fall through the cracks, or we called it the Swiss cheese of holes in the system. Because you you know you should be able to access your employer's plan, but sometimes there's a barrier to that, and then you may be able to access an ACA plan, but now they have about an $8,000 or $9,000 out of pocket maximum, and if you have to pay that every year, most people can't afford that. Um, then you may make too much to qualify for Medicaid, or perhaps your state hasn't expanded Medicaid. You're not old enough to get Medicare. You don't have a spouse to fall back on. There are a lot of ways you can fall through this very piecemeal system that we have, lack of a system. And it doesn't provide a lot of continuity or reassurance for people when something just bad or catastrophic happens.
Yeah, like I think that's one of the key aspects because it's when people end up in a crisis. You sort of mentioned this. They end up in a health crisis and they have health care through their employer, and it gets bad enough that they aren't able to keep working.
Yeah.
Then they have to, and there are options. There's the Affordable Care Act. Get on Medicaid, but there's all these but if you fall off of one health care and you're trying to get on a different health care, and then what happens in that intermediary time, is there going to be some, do you have a health crisis related to your ongoing health condition that means you have to go to the hospital? Well, you don't have health insurance. And then even if that doesn't happen, just the added stress of having to move from plan to plan and apply while dealing with often people have lost their job, and then they're really sick and they're struggling with this. I mean, this is why when it's one unified system that everyone is on all the time. That's a big difference. It's not just the people that aren't insured generally, which is bad. It's also the people that, the way I think about our healthcare system is kind of like for a lot of people, it works totally fine until you really need it to work, when there's a big crisis. And as soon as there's a big crisis, that's when things really go bad,
The bumps in the road, if you're fortunate, you can deal with those. If you're not fortunate, even that may cause a crisis. But yeah, it's really when you have a crisis that things can spiral out of control. But even with the serious illness that really relies on continuity of care, I've talked to people in what we would consider pretty ideal circumstances. Maybe they had a spouse that they could really rely on and they had good insurance. But then their company decided to change insurance providers at the end of the year. And now they have a whole different set of doctors. And so now they've got to go to a whole new set of doctors. So they've got to essentially petition a new practice to take them on as a patient. And they really need to get continuous care. And suddenly, they can't get in for however long, a couple of months or maybe more, to see a doctor. And it can be a big problem. Or all of a sudden they can get a denial, whether it's because they've changed plans or who knows why. And they can get a denial, and that can really disrupt the care that they receive.
Yeah, these gaps in care, and just availability. I mean, of like trying, because well, people have to be able to get in, then they have to be able to get into someone that sees their insurance. That reduces the pool even more of people that they can see. I know someone who had, it was really horrible actually. They basically had this like non-cancerous tumor, but it was still like, it basically made them, it like massively dehydrated them. I'm not going to pretend to know exactly how it worked. It was like, but all I know is that it got so bad that that their skin was just like all like horribly dry and painful, and they had this growth, and they were trying to find a doctor that had their insurance that could give them the procedure they needed. And this wasn't like, it was one procedure. It was get rid of this thing, and then it's not even cancerous. So all they needed was this one procedure, but they suffered in like agony for like over 6 months trying, because they just couldn't. And a big part of it was they couldn't find someone that had the insurance, a doctor who had the insurance coverage they needed to do the procedure.
And if they could have gone to any doctor, then they probably could have found one much more promptly.
Yeah. So if you could elaborate a little more on just like, you said you had pretty good insurance, but as speaking as someone who had what could be considered good insurance, did you still have problems with like medical care and insurance when you were diagnosed with cancer?
Well, yeah, I mean, I guess I had a couple of different instances. As time went along, my employer offered a choice of 2 different plans. And so initially there was only one plan, and I took that as good insurance. But as I said, especially with primary care, there was a real lack of providers, or there were quite a few providers, but none that were taking new patients. So, that there I ran into a lack of providers problem. And then even since then, sometimes if I've needed specialized care, especially for something with like symptom management, is what it's been more for me. But still, sometimes fairly serious things. There's been a long wait to get in to see a doctor that could help me, and so you're like, well, is it the plan or just lack of availability generally? because I think most of us have heard there's concern now and looking out on the horizon, even more concern about um, just not having enough healthcare providers to provide services to the American public. So even before delving into how good the array of providers is with your health insurance, you've got that barrier, but then just generally, are there going to be enough providers? And this is especially a big issue for people in, say, rural areas. I know I have family in much more rural areas than where I live, and frequently getting to the kind of care that you need is a big deal. It can be a very big deal. That's a huge problem for a lot of people.
Yeah, I'm out here in Oregon, and yeah, like in rural Oregon, there's at least one county where there's no just general care providers. Not a single one. At least that
Wow.
as of the data was a couple years ago. But I think it's unlikely it would have improved since then. And actually, as a last note, could you speak briefly in a couple minutes, since you were a nurse and you mentioned the sort of declining number of healthcare providers? Can you speak to why there are so many fewer nurses, why they're being overburdened with patients? Like, can you just sort of give a quick rundown on that situation in your experience?
Yeah, it's really interesting because different professional organizations can quote their numbers. They have really a remarkable number of nurses, and they'll put it, per population for like every so many people in the state. And um, like I live in Virginia, and I've seen the numbers, and I cannot recall exactly what they were, but how many nurses there are for the entire population. And it's not a bad ratio, pretty good. You allow for some, and that, they have the statistics, they know how old these people are. So you're like, well, that nurse is 80 and she still has an active license, but we suspect she's probably retired. And they, but many people have left the profession. And I think a lot of it is because of frequently the working conditions are not great. We've talked about increased patient ratios. That can be a problem. I think a lot of people in service professions have just found that the atmosphere is not just not super hospitable. And we really need to be thinking about that because, personally, I have friends that, there's me, I have a couple of friends in education, one who's a physician, who've all retired early, and it was largely because their workplaces were very inhospitable, and they were just not accommodating to them in terms of their reality that they were dealing with, both individually, but also as they were sort of on their glide path toward retirement. And there are ways that system can be managed to allow those people to go on and provide high quality care. And it's unfortunate we're if that's not done. And we should all be concerned about it because it just means that there's going to be less and less care, fewer and fewer resources for all of us. And those are really experienced people. Um, Especially if they're toward the end of their career, they're very experienced. There are kind of troubling statistics for nurses specifically about leaving the profession quite early. And these are people who've invested a lot of time, money, and effort, and other people have invested a lot of time, money, and effort in getting them prepared for that line of work, that type of profession. We need to be sure that uh, that that they have a satisfying career, but also that they're there to serve the public.
Right. So maybe a final question, because Walter, I think, is in the room. We want to
Yep.
bring up Walter too. And that is, what do you, what is it that people can do, right? It's one thing to talk about the problems, but how can we proactively change the system? What is it that you're focused on? What is it about One Pair States that has drawn you to the work that we're doing? Just very briefly, what is it that you would recommend that people do in terms of taking action?
Well, I like One Pair States because it's a grassroots organization, and that means there are actual humans involved, and we talk to one another, we know one another, and that allows you to feel like you're really having some control and some influence in the situation, even though you rarely feel like you really control the situation. But I think of things in sort of three different levels. There's federal level, state level, and local level. And, be sure at the federal level, that's a big picture policy issues. Be sure that your representatives know what your point of view is and that you feel like this is a really important issue um, for the American public and for people in their district. And then at the state level, I think, talk to your elected officials there too. Talk to professional organizations if you're in touch with them, or community organizations that do work at the state level, that make sure that they know that you feel like healthcare is important. It's really important to get good quality, affordable healthcare to everybody. And at the local level, it's nice to find a local group that's working on this issue. We have a local group where I am, and it's nice to know your neighbors, know their humans, know their faces, and sometimes you can collaborate on efforts to get the word out, educate people, and just make a difference in people's healthcare needs.
And
Because it's just so fundamental to people's quality of life. I think that's one reason I feel like this is just a super important issue, and I've been motivated to stay involved with it.
and I'd like to reiterate the National Nurses United and Physicians for National Health program
Yep.
that we said before. Chuck, you wanted to say something before we transition segments?
Just to express my gratitude to Caroline. She's just such a dear friend and a smart person who has taught me so much, who brings such grace, humility, thoughtfulness to the work that we're doing here. I'm just so touched and happy to be with you. You're just a real inspiration for me, Caroline. Really. Thank you.
Well, thank you, Chuck. Your inspirational leadership is wonderful, and I really appreciate it. So glad I found One Pair States and can be involved with such a great group. I appreciate it.
All right. Beautiful.
Yeah, thank you very much for coming on, Caroline. At this time, I'd like to remind you all that we're on GCPR Live, and we will be live every month on the fourth Thursday at 3 to 5 Pacific time, 6 to 8 Eastern time on One Pair State social media, and post live on various podcast platforms. Right now, we're going to transition over to our next guest, who we're so happy to have here, Walter. If you want to say hello and give yourself a quick introduction and what you're going to be talking about.
Well, thank you, Simon. And I thought Carolyn's talk was really excellent. It really helped sort of put into human terms some of the policy things that I want to talk about. And my name is Dr. Walter Tsu. I am a retired public health physician, but I served in many capacities in public health, including as the health commissioner of the city of Philadelphia and past president of the American Public Health Association. I've been active with Physicians for a National Health program that Chuck mentioned, and I serve as a national board advisor to PNHP. And I'm also on the Board of Healthcare Now, which is also an advocacy group for single payer. So for many reasons, I have been very embedded, if you will, or consumed by the idea of fixing our healthcare system, and I welcome the opportunity to talk about it. I should say at the start that when I went through medical school, I learned really nothing about public health. And my first job actually out of my residency was to work at a public health clinic, which I figure I would do for a year just to kill time, and then maybe I'll do something like private practice after that. And lo and behold, I was working in the public health clinic, and every day patients would come up to me and say, Dr. Tsu, I'm so glad you're here. I'm so glad we have this clinic, because I could not put food on the table, frankly, and pay for a doctor's bill or pay for my medicines. And I think that brought home, really in a very vivid way, sort of the dysfunctional aspect of our healthcare system. I mean, nobody who is really ill or sick should feel like they would have to sacrifice food on their table just to get healthcare. And the reality is that many people have to go to a public clinic to get their care, while you and I might want to go to a private doctor and get our care. And why should that be? Why, what is it about the fact that we have to create this other tiered system for people who are uninsured or poor or vulnerable? And I just thought, ethically, that just grated against me. I just thought that was a duplicative and wasteful aspect of our bureaucratic healthcare financing system. And so as the more I was interested in what I was experiencing on a daily level, I finally decided I want to actually pursue public health as a career and learn more about our healthcare system. And that's in large part about why I got very interested in the whole national health insurance single payer movement, because it became pretty obvious that we wouldn't have to have these public clinics or patients coming up and saying to me I couldn't really afford to pay for my medicines, if we actually had a national health insurance system that actually could provide basic services for everybody. And this, I might go to a private doctor, or you, and they were coming to me as a public doctor, is an illustration of a part of what I want to talk about today, which is a fundamental question about whether healthcare is a public good or a market commodity. Because if it's a market commodity, then it's pretty justifiable that if you're poor, you should go to this care over at a public clinic, and if it's a public good, then you should be able to go to any doctor that you choose, just like I could go to another doctor.
Mm-hmm.
It comes a lot down to one's personal values and ethics about what a healthcare financing system should look like. I happen to believe that one of the things that unite us as potentially as a country is if we all actually had to share into the healthcare delivery system, and that those who really are sick are the ones who can go further up the line, while those who are not as sick and maybe more worried, could take a step back and take their turn.
Yeah.
So someone
sorry.
like what Carolyn described as having cancer, she should be up near the front of the line because she needs care.
Agreed.
Well, this idea, I mean, when I was working at this clinic, one of the doctors there introduced me to this organization called Physicians for a National Health Program. She was also a doctor. And she said to me, you should learn more about this, because I think if you learn more about PNHP, you could understand more about how divisive and irrational our healthcare system is. And sure enough, I became much more active with PNHP. And one of the things that was a concept about that is the idea that we had a way of doing single payer financing or national health insurance that at least gave a basic level of funding for everybody in the country, regardless of their ability to pay. And those who really had cancer or strokes or something really devastating or serious, they need to be seen more right away. And that made a lot of sense to me as a physician. I mean, why should we triage based on your ability to pay? We should triage based on need, on what's important. The only way you can really think about it, do that, is if healthcare was a public good. Well, I got involved with the single payer movement a lot, and we often begin talking about the virtues of single payer. And I would sit in the audience, and I would look at the audience, and they would look at me totally puzzled, like they'd say, I don't know, I don't really understand all this healthcare stuff, and why single payers should be paying. What about married people? Why should the singles be paying for this? And I mean, it just goes to show you the basic level of I would say, health insurance literacy that is deficient in our society. Most people could not tell you the difference between Medicare and Medicaid. They couldn't tell you what a copay or deductible is. They don't understand any of these other things, including things like in-network, out-of-network, prior authorizations. These are concepts that are truly foreign in any other country except America, because America, we happen to do this dysfunctional bureaucratic healthcare system that we have. And it strikes me that the confusion about single payer is partly because we have been bad about teaching what a healthcare system should be. We should talk about it maybe right from the start from a values perspective. And so I think we should take a step backwards and ask us a more fundamental question about whether you believe in single payer or national health insurance or whatever. And ask a basic question about whether healthcare is a public good or is it a market commodity? Is it something that, we have public clinics and private clinics and then concierge clinics and all kinds of other fragmentations that we have in our system, and we finance it all in different ways. And it's the reason why our healthcare system is so expensive is around this eligibility question. Because if it's a market commodity, then do you fit into the right category? Are you a veteran who happens to have X number of years of service, and then you get this type of care? Or are you an elderly person who happens to be dual eligible, and then you get this other care? Or are you, a healthcare worker or Joe Schmo or Joe Homeless, and then you get another type of care? And I just think the amount of money that we spend to pay someone to determine which category you fit in is not a trivial amount of money. It is, in fact, the business of what private insurance spends much of their money on, is to figure out whether you're truly eligible for our plan or not. And that's bureaucratic waste. If healthcare was a public good, then that eligibility criteria goes away. Everyone's eligible if it's a public good. If it's a market commodity, we have to go through all these different filters and hoops to decide who gets healthcare. And that costs a huge amount of money. It's part of the reason that the private insurance industry tries to justify their existence, because they're the ones who can arbitrate whether you're whether you're a quote covered live or not a covered live. And if you're not, then we don't have to deal with you at all. And your problem is your problem, and you go find someone else to take care of your cancer, and maybe someone else would be willing to cover it. I mean, that's
Walter.
a crazy system.
Yeah. So, I mean, really, you're talking about waste, fraud, abuse, and profit first, right? Which is to say that the profit making is baked into the formula, the formulary. They have medical underwriters who make these determinations, who come up with these algorithms, who come up with these demographic determinations as to whether you're covered or not. And now, just to pivot a little bit into the presidential campaign, since this is on the minds of a lot of people, right? Is just that, and we're not going to even invoke the political party names. We'll just talk about candidates. J.D. Vance, in particular, has talked about restoring the ability of insurance companies to exclude people because they have pre-existing conditions. Something that, as critical as we've been of the Affordable Care Act, is something that this particular ticket is talking about bringing back, right? Which is giving the ability of the insurance company to keep people from getting exactly what they need, right? Exactly what they need, precisely what they need. Can you speak to that a little bit, and maybe generally about where we are in this election season, since this is weighing heavily on people's minds?
Well, the general philosophies of the Democrats versus the Republicans. The Republicans really want to privatize healthcare in every aspect. So that right now about 51, 52% of Medicare patients are in Medicare Advantage plans. The Republican plan would basically to move us off traditional Medicare and have everyone privatized in a private Medicare plan.
Can you explain
Uh,
that? Can you explain that? A lot of folks are not familiar with that phenomenon.
yeah. Well, when you turn 65, you get a big book called Medicare and You or something. And in the first 2 pages, they tell you you have a choice. You can either choose traditional Medicare, that's the one that says you're over 65 and it covers 80% of the bill. And if you want the other 20% to be covered, you have to buy something called Medigap insurance. And it, by the way, it does not cover hearing, dental, and vision. And there are other parts to it, like something called Part D that covers your prescription plan. So if you want drugs, it's like this a la carte menu coverage. Then you have to add an additional supplement called Part D for your drugs. If you want to pay for your doctor visits, there's something called Part B, which pays for doctor visits and durable medical equipment and other things like that. So it's a bit confusing. In fact, it is confusing for most people. The Medicare Advantage people say, don't worry about all that. Put it all under one umbrella. You get one fee that you have to pay, and we will take care of your drugs and your co-pays and everything else. And by the way, we'll do your gym membership, and we'll do a little bit of dental, and we may even throw in hearing aids and so on. So it's a little bit more, sounds more comprehensive when you hear it that way. So how can they afford to do that? Well, they don't tell you this in the marketing material, but they do. But what they do is they have something called narrow networks. And they'll have something called prior authorization. So every time you have to get some procedure, if you get sick, it's kind of like the game of Simon Says or Mother May I. So if I don't say you're authorized to go ahead and take the next step, you don't get it. And we get to decide, the insurance company gets to decide whether we're going to give you prior authorization. And by the way, you cannot pick any doctor you want, even though you may have had a 30-year relationship with your doctor. You have to have a doctor that's in our network. And we decide who's in network and who's not in network. So there are a lot of these bureaucratic things that people don't realize when they sign up for Medicare Advantage that they have to go through. And that's how they are able to tie all this stuff together. It turns out that if you go through all that bureaucratic hoopla, Medicare Advantage is making a ton of money from the federal government. And we as the taxpayers are overpaying the Medicare Advantage plans, PNHP estimates something like $140 billion a year. You want to know why we have a federal deficit as big as we do? It's because we're paying private plans like Medicare Advantage this exorbitant amount of money. So you multiply that for 50 years that we've been doing this, and no wonder we're $30 trillion in debt. That's part of our big problem as a country.
So can you spell out clearly to folks who's behind Medicare Advantage? And if it is private insurance, how are they able to even use the term Medicare? How are they able to use the most popular governmental program for healthcare? How are they able to even use the term Medicare?
Well, when Medicare was passed in 65, there was no Medicare Advantage programs. Sometime around 1973, I think, the private insurance company said, there's a big gravy train amount of money here for senior citizens, and we want part of that money. So they went to the government and said, listen, you give us like 95% of what you would normally spend on a Medicare beneficiary, and we'll take care of them, and you get to keep the 5% for yourself. Well, the government said, well, stupidly, this sounds like a good deal for us, right? We get a 5% discount, and we give all this money to private insurance companies. And at that time, they called it Medicare Part C, or Medicare Plus Choice. And later on, not exactly when, the insurance companies came back and said, we'd like to change the name from Medicare Part C because people don't really understand Part C. We want to call it Medicare Advantage. And so they did the Medicare name. They made it sound like Medicare is endorsing these private plans. And in truth, they managed to come up with all kinds of schemes in order to keep the healthy people into Medicare Advantage and throw out the people who really were not healthy, because that's how they could make a lot of money. So, for example, they used to have orientation things, and maybe it was on the third floor with steps, and you had to walk up to the third floor to get into the dinner or lunch that they gave you for free. Well, guess what happens? Well, these people who can't walk up the third floor with congestive heart failure and diabetic neuropathy and so on, they're out of the plan. They can't make it up there, so they don't get lunch, but they don't get into the Medicare Advantage plans that they schemed. So the marketing people the people at CMS got wise and said, you can't do this anymore. But increasingly, what happens is that there are brokers out there. Brokers get paid to get people enrolled in Medicare Advantage plans. If the brokers enroll you in a traditional Medicare plan, they get paid nothing, zero. So guess what? If you're a broker and you watch this on television all the time, all this 800 number, a broker will talk to you about what healthcare plan you can do. What do? They only tell you about the Medicare Advantage plans because that's how they get paid. And it's a marketing scheme that they've come up with, and that's how it got called Medicare Advantage. In truth, it should be called Medicare Disadvantage, because once you get into the plan, you're sort of trapped into the plan. You realize now suddenly that you have to do this prior authorization, these narrow networks that may not include your doctor. There are narrow hospitals that may exclude, for example, the best tertiary cancer treatment programs, hospitals in the country are excluded because they're too expensive. So the Medicare Advantage plans don't want them. So they tell you, go to your community hospital for your cancer treatment rather than to an NCI designated cancer treatment program. I mean, these are the kind of crap that you have to go through. And then you fight it. And finally you say, I want to get out. I want to go back to traditional Medicare. And so you do go back to traditional Medicare. But guess what? Traditional Medicare only pays 80%. The other 20% you're stuck with. And what happens? How do you get the other 20% covered? You have to buy Medigap insurance. But here's the catch 22. The Medigap insurance says, oh, guess what? You have a pre-existing condition. You have cancer, and we're not going to sell you a plan. Or we're going to sell you a plan, but it's going to be like 4 times as expensive as what we would normally charge because you have a condition. Can they get away with this? I thought we got rid of pre-existing conditions. Yes, they can, because Medigap is excluded from this pre-existing condition clause. So the problem is that most people, once they get into the Medicare Advantage, they're trapped into the plan. They realize that they can't, that if they go back to traditional Medicare, they're kind of screwed by this bureaucratic system we've created, except for 4 states, which what they have called guaranteed issue for Medigap. Those states are Connecticut, Maine, Massachusetts, and New York. Except for those 4 states, like Pennsylvania, where I live, you're screwed. You cannot get Medigap insurance except for really high prices, or it could be denied to you. So that's why I tell people, when you open that book when you turn 65, and you have to make that first choice, and it sounds attractive to sign up for Medicare Advantage, you better think twice about it, because the truth is that it really is a disadvantage to trap you in the program, and you would wish at that point that you were in traditional Medicare and with the Medigap insurance, because then you could go anywhere to any doctor, any hospital, and get the care that you really deserve.
All right, so we are coming up to our next segment. But if you want to spend, do you want to spend just a couple minutes wrapping this back around to the topic of public good versus private with healthcare delivery and insurance?
Well, one of the things that people always say is, how are you going to pay for it, right? Well, how do you pay for other public goods? What are public goods? Public goods are things that we as individuals cannot afford by ourselves, but collectively, all of us together can benefit from. So the road in front of your house, someone comes by and does wastewater treatment. I mean, imagine you have to do your own wastewater treatment. You couldn't do it. You go bankrupt. We collectively use our tax dollars to fund those type of things. We fund our hospitals, our police departments, our fire departments, our public education, our public health, our national defense, all are funded through our tax dollars because they are public goods that we invest in. If healthcare were a public good, which is what it should be, we could eliminate the $900 billion of the private medical industrial complex. And that money then can be returned to lower your taxes, frankly, and make it much more cost effective to provide health care in this country. And the reason why drug prices are so expensive in America, Bernie Sanders just had a thing on Ozempic, and he said, in other countries, they pay 1/5 of the cost for Ozempic that we pay in America. Why are you gouging the American taxpayers? Well, the reason why is they set the price based on how expensive our healthcare system is. And they figure out how much would it cost for bariatric surgery and obesity treatments and all the complications. And that in America turns out to be hundreds, if not millions of dollars. And then they say, okay, and we're going to avoid that by pricing Ozempic and Wegovy and all these other drugs at a much higher price than other countries, because our healthcare system is so dysfunctional that we pay so much money that's how they justify charging so much money for treating something like obesity, because the alternative that you have is to go through very expensive bariatric surgery or some other weight plans or something. So we suffer because we have this dysfunctional healthcare system, and it's how the drug companies decide to charge us these exorbitant rates based on the fact that we have a dysfunctional system. If we actually had a rational system like every other country in the world, we would be paying 1/5 the cost of these prescription drugs, just like the rest of the world.
All right. Well, thank you very much, Walter. We're going into our final discussion segment. It'll be so please stay on the line. Caroline, if you're still around, you can join in as well. Chuck, you look like you.
Should I mute? Should I get off?
No, you should. You're here. This is our last back and forth chat. Chuck, you want to say something? You're muted on the Zoom call at the moment.
Yeah, I was just going to say, why don't we just, for people who just joined the program, just reintroduce them, right? This is our half-hour break. Who we are. You want to do that?
I will give them the spiel, and then you can reintroduce both our guests. So thank you everyone for tuning in and listening on GCPR Radio or on social media or listening post live on podcast platforms. This is To Your Health Care, hosted by myself and Chuck from One Payer States, onepayerstates.org, fighting for a national healthcare system through the states. We are going to be live on GCPR Radio and social media every fourth Thursday from 3 to 5 p.m. Pacific Time, 6 to 8 p.m. Eastern. And we have been having a great show thus far with both our guests, Chuck and myself. And Chuck, do you want to lead us into our final Envisioning Success discussion segment, reintroducing our guests and sending us in there?
Yeah. Thank you, Simon. This is our inaugural launch. This is a lot of fun. I really appreciate the opportunity to have a long segment of conversation where we get more in depth and really get to know our guests and present what it is that we're doing and thinking in the movement for guaranteed healthcare for all, cradle to grave. This is what we're about. We want to make sure that the United States becomes a leader, frankly, in the cause of civilized healthcare for all. This is something that I trace back to the Universal Declaration of Human Rights. This is December 10th, 1948. This is Eleanor Roosevelt. This is a monumental moment in the aftermath of the Second World War, where the United States and all of the nations of the world agreed that, among other things, healthcare was a human right. Healthcare is a human right, and that also included jobs, housing, education, environmental protection. The list goes on. But that, in many ways, is a high point of human history. December 10th, 1948. For me, that's the North Star. That's where we need, I think, to stay focused. And it was, almost exactly 75 years ago. And here we are going into an election where we're very much at risk of going deep into fascism. Well, let's keep it real. I mean, and what that means is that the merger of state corporate power, in addition to the ideology of white supremacy, in addition to the radicalization of religion, which is to say religious nationalism or Christian nationalism predominantly. These three spokes right now, right? State corporatism, religious nationalism, and white nationalism are really a threat to the United States and to the larger world. And so our work at One Payer States, we're mindful of this larger picture. We don't get stuck in the silo of healthcare only. We're concerned with how we connect our healthcare campaign to health, all the other health campaigns, right? We talked about this at the very top, but it bears repeating because we really need to be talking about a strategy that's going to allow us to bring together people to win on all fronts. And we can have the best healthcare system in the world, but if we don't have a healthy society, that healthcare system is going to struggle. We have to create the conditions for a healthy society where everybody is housing, jobs, quality education, environmental protection. We're dealing with the climate crisis. So this is the work that we're doing at One Payer States, and we really want people to join the fight, join the effort, join the campaign, and to be really thinking strategically. So, and I'll finish with this, and that is that what we do here at One Payer States and also the Justice for All network which is a partner of One Payer States. We do intergenerational summits. We bring people in to talk about disability rights, to talk about reproductive rights, to talk about LGBTQ, trans rights, to talk about housing, to talk about climate, all these other issues, is that we're about radically visioning the future. It begins with radically visioning, which is to say that in order to create an effective strategy, I am absolutely convinced we need to see the success of the future, and we need to keep that vision in the forefront of our own thinking, and see that success where everybody has health care justice and health justice. And then we begin to ask the question of how did we get there? Reverse engineer the question. How did we build the leadership, the new leadership? How did we build effective critical decision making? How did we build campaigns that win short-term, midterm, and long-term? How did we create the effective and necessary coalitions? How did we bring together all of our people? And I'm very excited, as I mentioned at the top, a lot of people miss this, working very closely now with Congresswoman Pramila Jayapal, who, along with Bernie Sanders, are the leaders on healthcare justice in this country. And what's very exciting about Representative Jayapal is that she wants the states to work, the state campaigns to work very closely with the national campaigns. And that's something we really need to lean into in terms of creating a movement that's cohesive and coherent and working together. People may disagree on tactics, that's fine. But it's important to refrain from shooting at each other, right? The circular firing squads. We need to be partners. We need to work in solidarity. And the reality is the history of our country is built on creating models of success at the municipal and state and now even regional level. And that's the direction that we're going with One Payer States and the Justice for All Network. And that's the exciting part of our conversation that I really want folks to engage and to be involved in. So as we lean into this huge election coming up on November 5th, I think it's important to be mindful of that larger strategy. It's not just Harris versus Trump. It's about the vision of seeing our success in the future, 5, 10, 15, 20, 50 years down the line. We have to see that success. Let's just call it a utopian society where we all care for each other. And how did we get there? We have to ask ourselves, how did we get there? And so this is a question that I'd like to pose to Caroline and Walter and Simon, and bring other people into the conversation, however we're able to do that, about how were we able to do that? How were we able to succeed? And that does require setting aside a lot of our negative assumptions in the present, our fears, our anxieties, and really leaning into what I call radical hope, radical hospitality. Radical hope, of course, is actually seeing that vision and believing it. Radical hospitality is welcoming the conversation with everyone and listening intentionally. We have 2 ears and 1 mouth for a reason. And the other piece of that is again that keeping that clear strategy in mind, being very intentional in how we build out that strategy and all the different components that are involved there. So I'll stop there and ask any reflections or thoughts that you all might have, Caroline and Walter, about how, if you can hold that vision in the forefront of your mind, what is it that we need to do in the present to get us to that point? In other words, if you reverse engineer that success, what is it that we did to succeed? What is it that having accomplished that goal of universal transformational justice, what is it that we had to do in the present to achieve that? Whether it's this election, the passage of certain bills, the building of relationships, what are your thoughts? We'll start with Caroline and then pivot over to Walter.
Well, I think I figured out a long time ago that if you're going to live in a democratic society, small d, it involves a certain amount of goodwill and reliance on goodwill of all the participating parties. If somebody really wants to step up and sabotage things, then the system's probably going to break down. So, on the positive side, I think, you have to be able to rely on that reliance, to feel like people are coming to the table to participate in this sort of system, and you have to be able to work together to find solutions. I mean, everybody wants to have a good life, no matter how they define it, and you hope that there's enough consensus that you can build a framework that people can live with and everybody can have a good life. And I think, that's one of the reasons healthcare is important to me. I think that's a really fundamental piece of everybody's uh, striving to have a good life, is that you've got to have your basic healthcare needs met, or well, you might be dead, but you're certainly not going to have a good life if those aren't met, and you manage to still stay alive. So, I think focusing on trying to do that, trying, like you said, to work with everybody out there, everybody coming together to try to find solutions. That's really what's required in order to move the process forward.
Excellent. Thank you for that. Walter?
Well, if you look at surveys about the popularity of national health insurance, it's surprising that something like 70% of Democrats support the idea, and even 40% of Republicans support the idea. And if you interview many Trump voters, the thing that they often say that they'd like to see the next president do is to bring us together, to unite us in some fashion so that we stop all this bickering and that we come together for maybe a common belief or a common cause. Well, it turns out that the radicals have somehow labeled Medicare for all as a left-wing radical idea. That's actually portrayed, I think, by the insurance industry, medical industrial insurance industry. The truth is that Medicare for all is a very common sense, mainstream, I think neutral idea for us as Americans. It's a general belief that healthcare is a human right, that all of us need healthcare sometime or another, that, even as a hurricane hits the city, Florida, all the people in Florida kind of come out of the woodwork, regardless of political affiliations, and help their neighbors if they were faced with a disaster. That's what Americans do. That's what we should do. That's what a healthcare system can do, is that it's not based on whether you can afford to get the type of care you need. You broke your leg in this terrible hurricane, or something terrible happened. We come together and we help each other, and we're a charitable country, and that's what I think our healthcare system should look like. That's why I think one of the first things we do, and why I talk about this, is get people to fundamentally understand that healthcare is a public good. It's a public good. It's not a market commodity. And the more that people out there start understanding that healthcare is a public good, then it's easier for us to talk about things like national health insurance or single payer, because it's the natural extension of actually healthcare as a public good. It's how we would finance healthcare as a public good. But the first thing we have to do, and how we got there, doing your radical engineering, is that we got Americans to understand that healthcare is a public good. Because once they understand that, then it becomes much easier for us to make the transitions for creating the financing system that allows us to have healthcare as a public good.
Beautiful. So there's a nice synergy there between Caroline's comments, which is people want to have a good life. And what's fundamental to getting a good life? That's this collective belief that healthcare, and really all of our institutions, our public institutions, all of them, right, need to be seen as part of that common good. And just to borrow the language from our Constitution, which is repeated again and again, it's called the general welfare, right? The general welfare. I mean, that's the same thing, right? So if we can center our thinking and our actions on those concepts, I think we're going to do very well. What are your thoughts, Simon?
Well, I'm kind of thinking about healthcare as a public good and what Caroline said about everybody wanting to live a good life. And, I think there's so many different ways we can envision this success, envision this utopia. It's such a broad topic. I want to focus in on like community. And I think this links back to seeing healthcare as a public good. I think that when people are isolated, when people feel isolated and lonely and disconnected from their communities, it really makes the ability to see other groups as the enemy, to instill fear and doubt, very powerful. So I see our future society where we have national universal health care for all and have made great gains in many other social justice areas. What we did is we came together and we made a real effort to bridge gaps that have been growing and growing, in many cases, I think intentionally. People are atomized in their own lives. They're isolated in their own lives. They go to work, they come back home, maybe they talk to people on the internet. They work and home, they don't have any third place they go to. They have very few friends. I mean, I see this a lot in people my age. And in that kind of environment, it makes fear very palpable, and it builds on the sort of idea of American individualism, right? Which I don't think is entirely negative. I think self-reliance and determination, and I think there are good aspects to American individualism. I don't think it's entirely bad, but it makes people see others as the enemy. I mean, I always think back to this time. When I was younger, I was maybe 18. I was in Indianapolis for a conference, and I had another guy was there. Another guy a bit older than me, sort of in his like 21, sort of white guy. And I had never really noticed. I mean, I grew up in a very sort of very like white area. I noticed that in Indianapolis, all of the service workers were black. This was something I noticed, and I didn't really know even what to think about it, because I didn't really have any like ideas of like anything systemic that could have contributed to that. But I noticed it, and I thought it was I was like, this is weird. This seems instinctually wrong. There was a divide, right? A very distinct divide. And I brought this up to him, and his reaction was immediately like, why are you talking about this? By talking about this, but like everything is fine, but as soon as you're talking about this, you're like magical thinking. You're forming this reality into existence that there is a problem. There wasn't a problem until you talked about it. And I feel like some of that is a reaction of not being exposed to different people, different ideas, and seeing people as the other, and this isolation. And I think to make progress, to go to that world, what we did, we worked to create third places, community spaces, built community, changed the thinking so that we see things like the right to healthcare, like healthcare as a public good, that we see the instinctual, the sort of intuitive value of everyone living a good life, build that community and that connection between people. And I think that's what we had to do to reach that better society. I think that's an integral point, because as long as we're so isolated, so fearful, I think we aren't able to get there, but we did once we really tried to focus on building that community and connection between people.
Wonderful. Yeah, really different ways of getting to the same point, right? Which is, I mean, we're all, I think, in connection here, relationship building, seeing the public space as as sacred. Really, the public space is a sacred place. It's a place that needs to be, Walter, right, nurtured. It needs to be protected. It needs to be cultivated, and that's where we center the effort to create a truly comprehensive and efficient and effective healthcare system, as well as education, environmental protection, and so forth. And then just getting down to brass tacks with Caroline, talking about we all just want a decent life. We all just want a good life. Why it's the vast majority of us do not aspire to be billionaires. And yet we're living in a society where the billionaire class is using it fundamentally is using all these tools of fascism to divide and conquer, and to Simon's point, to scare us, to keep us thinking about, oh my God, these Haitian immigrants, they're eating, pets in communities across the country. I mean, this kind of absolutely ridiculous, over the top narrative, unfortunately, as ridiculous as it sounds to us, it does permeate, to your point, Simon, for people who are isolated, fearful, and are easily swayed with this sort of othering narrative, right? Which is to say that they don't look like us, they don't worship like us, they haven't been in our country as long as us, therefore they must be less than us. And therefore we have these negative feelings toward LGBTQ, in particular the trans community. This is the most vulnerable of all the communities, and immigrant communities, women. I mean, you've got a narrative out there that is completely out of the box. I mean, let's take a look at Project 2025 very briefly, and what that would do. The design of the Heritage Foundation is designed actually to even more radically privatize our healthcare system. Right, Walter? The Project 2025. Have you studied that or looked at that?
And they want to totally privatize everything in healthcare. And everything we know about private insurance is that you will pay much more. They get to decide what they want to spend their money on and whether they're going to pay your claims or not. They can delay whether necessary treatments or expensive medicines or something that they want to pay for or not. In the meantime, your cancer is advancing or your disability is getting worse. And finally, you get to the point where you don't make it. And actually, it's not a good thing. I mean, there are lots and lots of stories about that. So because time's short, I won't belabor that. But you're right. It's a serious problem if healthcare is totally privatized. Healthcare insurance is totally privatized, and there was no Medicare, no Medicaid, no veterans care programs. It would all be done through private companies.
Yeah. Caroline, you want to add to that?
Yeah, well, I'll just say that it's so true. And we've had presentations, I know, at One Payer States on just why the market model doesn't fit healthcare very well. And there are a number of reasons that we don't really have time right now, but maybe that's a topic for a future program. Why that model just doesn't work real well with the healthcare system, even for those who would like it to. If you're on a gurney in an ambulance, you can't really do research on the most cost-effective hospital to go to. So there are a number of reasons that it just doesn't work. It just doesn't work in that context.
Yeah. Whether you favor capitalism or oppose it, where healthcare is concerned, it needs to be divorced from this truly wealth extraction the system that is designed to extract wealth, and as its first imperative, as opposed to delivering good health care and providing a safe environment that allows the professionals who are trained to deliver the health care to actually do their job and to do no harm. I think you said that earlier, and that's the core tenet that physicians and nurses are taught when they go to school: do no harm, right? So thank you. do you want to, Simon, do you want to sort of just kind of pivot here and keep people aware that we're going to be coming back a month from now? And just want to express gratitude to Simon, who has gone to great lengths to put together the technology to get this program off the ground. There's so much background work that's being done. So I just sort of showed up. So I had the easier job, but I just want to throw some kudos in the direction of Simon, with whom we've had wonderful opportunities to partner this year. Just to repeat, Simon came back to DC for a week. We did lobbying, we talked strategy, we did some organizing work. And then we met again a month later in Baltimore at Netroots Nation and did amazing networking and connection. And that brought me into the awareness of the Comstock Act. If people haven't heard about the Comstock Act, that's another program embedded in Project 2025, which would create a national abortion ban through a zombie law, a law that was created in 1873. This is the Comstock Act. Anthony Comstock, who passed this bill in 1873 that hasn't been enforced since the 1920s, and yet the radical right wants to bring it back as a way to create a national abortion ban. This is crazy stuff, but it's real. And so, for folks just to even get a taste or a summary understanding of Project 2025, I think that's really important information. And then I guess the other thing that I would say, and then hand it off to Simon to finish things off, is I'm knocking doors. I think that everybody has said here that the best way to build solidarity is to come in personal contact with people as much as possible. There's nothing more powerful than talking to people at their doors, in marketplaces, farmers markets, stores, and what have you. That's how you really touch people as much as possible. God bless folks who do the phone banking and do the postcarding and connect with people other ways. But for me, it's that personal contact. And here we are on radio, and just grateful that we have this opportunity to have been with people tonight. One Payer States, Justice for All Network. So happy that we're together, and gratitude to Caroline Coram and Walter Tsu and Simon Hutton. Simon, do you want to wrap it up?
Yes, I'd like to thank both our guests again, which you already did, and thank you for showing up, Chuck. We are going to be live every fourth Thursday, 3 to 5 p.m. Pacific, 6 to 8 p.m. Eastern. Catch us on our social media, Facebook, Instagram, TikTok, and everything else at One Payer States. Check us out at onepayerstates.org to see the work we do. And if you'd like to support our work, we would very much appreciate it. We will be back in a month. Thanks again to all of our guests. Thank you to my co-host, Chuck. And we are signing off. Have a good night, everyone, and we look forward to